management in acute type A dissection with malperfusion, I think it's a very important topic. Why? Because it's the second most common complication in acute type A dissection after aortic regurgitation. It occurs in 20 to 50% of all cases, and it causes a higher mortality, around 2 to 3 times higher than with normal acute type A dissection. So actually you have a dilemma. You're not only dealing with an acute type A dissection where you need technical skills, but you still have only 2 anastomosis to fix and you'll be fine. Now you're having malperfusion, and you can have this malperfusion before surgery, during surgery, and after surgery. So actually you're having several problems. So it's not only about technical skills, now you need experience and judgment. Really, this is very important. Every single organ that comes out of the aorta can be actually potentially involved, mostly heart, brain, and visceral. Renal, of course, if you have a problem, but you can still go on substitution therapy. Spinal is very rare. And limb ischemia you can mostly fix when you do the surgery. What's the dilemma? Well, the dilemma is that that's a complication that is out of your hand. Because, you know, in the last 20 years, gladly emergency rooms in big hospitals really think about type A dissection. But if you have a patient referred from a small hospital, they might mislead those symptoms, and that costs time. And this time actually will put you into a bad spot when you do the surgery. What is important to know is, do you have malperfusion with organ failure or without organ failure? And that makes a difference. If you look at this, if you have only subclinical symptoms, you're still going to do fine. But if you really have clinical symptoms, and that's a Penn classification ABC, then mortality goes really up. So actually, as a surgeon, you would have to ask yourself 3 major questions. Shall we operate on those patients at all? Shall we first treat malperfusion and then do the dissection? And what is the outcome if we do surgery on those patients? And once again, coming to that survey from Canada, I think this really reflects real world. Those surgeons were asked when would they reject surgery in acute type A dissection. And of course, it was very interesting. Active CPR, most of those patients was rejected. But if you look at malperfusion, this also makes sense. 26 would reject surgery when you have a major stroke, followed by mesenteric ischemia, paraplegia, and limb ischemia. What was really interesting, if you look at the questionnaire, there was no question about coronary ischemia, because most of us would really not reject a patient who has coronary malperfusion in acute type A dissection. But that's a paper that came out just a few weeks ago from the Nordic groups looking at malperfusion in over 1,000 patients. 33 had malperfusion, and coronary malperfusion came out 25% of all cases. So that's a high number. And if you look at mortality with coronary malperfusion in this group, it was higher than actually with cerebral or gastrointestinal malperfusion. It gets even worse if you have malperfusion once you've fixed your problem. If you have malperfusion after the surgery, and this is a paper from the IRA database, you can end up with a mortality of 57%. Same is true for the Gerada database. Pre-op coronary malperfusion, brings you to a higher level of mortality. Post-operative coronary malperfusion, you're going to have a 9 times higher mortality. So you have to fix that problems. And actually, long-term follow-up is worse if you have post-operative MI. So please think about it. Coronary malperfusion is very important. What about cerebral ischemia? Gladly only in less than 10% of those cases. And this is a paper from a Swiss group, 300 patients with acute type A dissection. Out of these, 53 had cerebral malperfusion, and they were looking actually at modified Rankin score or Glasgow coma score. And actually those who had some neurological deficit had a higher mortality, which was true, but those who actually recovered had a quite low mortality. It was 0%, so there is some room for those patients even if they present with cerebral malperfusion. The only 2 factors that were actually predictor for persistent neurological deficit was modified Rankin score that was higher, and a dissection of the right carotid artery occlusion. What about if you push the envelope even further and you would treat patients with a coma? And this is from Dr. Akita. Out of 241 patients, 12% had actually coma, and most